and retired from his service in the year 2018. Remarkable achievements from Sir are too many, but to name a few, Sir has been awarded with National Sushruta Award and the Best Teacher Award by RGHS and National Sushruta Association. Sir, I hand over the session to you to start it.
Okay, if you allow me to share the screen, I'll start. Okay, I think the screen is visible. Uh, Now I am supposed to talk about chest X-ray in relation to the respiratory disorders. Now, X-ray is one of the simplest means, or rather, most economical means of investigating the diseases related to the respiratory tract, and most commonly used also. To basics of radiology is based upon the structure which you have and its radiation coefficient. Now, I'll not go much into the details of that, but from the point of view of structure of the respiratory system, the lungs, the bronchi, the trachea, these constitute a air-containing bag-like structure, and that would have the specific anatomical differentiation of the branches and then the alveoli, which are really catching the air as such. So, to understand the basics of radiological image, there should be a fair knowledge of the gross anatomy. So it's after all the gross anatomy which is read as the shadow, and hence from the radiology imaging point of view, it's absolutely necessary that we have a fair knowledge of the gross anatomy. And of course, I will not go much into that issue now. We'll directly go into the issue of diseases. Ultimately, the finest part of the lung tissue is the alveoli, where you will have a single layer of epithelial tissue containing air, and this would be seen in a X-ray image. So, with this very brief about the basics of the anatomy, I'll directly go into reading of a chest X-ray or identifying this anatomical structure in a chest X-ray. See, after all, chest X-ray would be a two-dimensional image of a three-dimensional body, and hence there is a need to orient yourselves to the image as such. The structures which we will be able to see also would depend upon whether there is a air contrast around the area or not. The soft tissues as well as the hard tissues like the bone, they may mask the area, and hence the visible extent of the structure and identification of these structures by the standard parameters would be the midline. You will have the vertebral column, which will give you the mid-axis, the spinal process, and the spinal processes are seen, vertebral bodies are seen in the middle. The ribs would form the hard cage as such of the thoracic cage, and then the soft tissues around would be covering the area, which also will produce a soft tissue shadow. And the structures of the lung tissue is visible through the soft tissues of the body, and it's also seen through rib cages, the space between the ribs as such. So we will have to study these lung patterns, the vesicular pattern of the lung tissue, the alveoli. They are seen as fine, small network, fine network as such, and they show you the normal pattern of the alveoli. And then, of course, as you come in, the bronchial divisions, the bronchial tree, the finer branches of the bronchioles and the bronchi are seen, and they gradually become wider towards the medial side from the periphery to the middle, or they taper from the midline to the periphery. And then you will have the hilar area where you will have some few lymph nodes as well as the major vessels, the blood vessels, as well as the bronchi. They would be moving through. Now, whatever we see as the lines over here, they are the combination of both blood vessels as well as the bronchioles, and hence we call them as the vascular markings. Now, vascular markings are somewhat thicker towards the medial side and they become thinner towards the periphery. And in X-ray, chest X-ray, only the medial two thirds you will be able to see them. Beyond that, that would be an abnormal. So, normal X-ray would show you only that. Hilar areas would have many lymph nodes, and normally these lymph nodes are not opaque and you will not be able to see them in large numbers in the X-ray. But of course, a few of the lymph nodes may be visible, and one or two of the lymph nodes being calcified is not an important issue. Then, of course, the cardiac shadow, the precordium, that it constitutes the major area of the chest X-ray, where the heart, as such, as a whole, the periphery of the heart would be seen, and aortic knuckle also forms the midline. Trachea can be seen to a certain extent as a lining containing the air. In the air would be suggested as a black color in plain X-ray, and this can be seen. So that's how we may identify the normal structures to read when we X-ray image is given, and if you have to read the X-ray, the first of the thing is you have to see whether the image is properly qualified or not. When I say qualification of the image, it also depends upon the position in which the X-ray is taken and the other technical aspects. Position in which the X-ray is taken also depend upon the indications, the purpose of going for the X-ray. The indications for chest X-ray could be varying from a simple condition like a inflammatory pathology of the lung to the extent of malignancies related to the respiratory system, or it also could be related to the bony structures like injuries to the bones or displacement of the bones, which could be studied by the X-ray, or it also could be related to the extrapulmonary pathologies. Many times, some of the lesions of the abdomen also could be read if they are finding in the chest X-ray as such. But all that what we would be focusing today would be about the respiratory area. Now, in the majority of the respiratory conditions, the usual view is either a AP view, anterior-posterior view, or posterior anterior view, or the other way, or a lateral view. These are the commonly preferred X-rays. Now, for the respiratory pathology, posterior anterior view is more preferred than the AP view. AP view is more preferred for studying the vertebral body pathologies or the lesions of the posterior surface. Now, to visualize the structure or visualize the independent structures, the technical quality of the exposure should be proper, and then only you can make out the difference between the soft tissues, the hard tissues, the air. And this would be what we call as a contrast. The contrast of the X-ray, if it is proper, then you will be able to distinguish these structures clearly, as you see in this image. Of course, a poor contrast and variations, I will not go into that part now. And once the contrast is proper and the X-ray is in the optimum position in which you need, then only the further progression into the reading of the X-ray is possible. Otherwise, of course, it will not be useful. Then once you have the image X-ray film in front of you, you hold it in such a way that as if the patient is facing you, and by which you can determine which is the left side and the right side. Of course, usually the technicians would mark the left and right, but many times if they miss that, they'll have to make out which is the left side, which is the left and which is the right side by based upon the anatomical aspects. And to do that, and as well as to have a proper orientation of the image, you also have to decide whether the patient's positioning during the X-ray is proper or not, and that's what you call as the centering of the X-ray. Centering of the X-ray is now in a typical PA view, posterior anterior view. The spinal cord, the spinal segments, they form the midline of the posterior surface, whereas the sternal heads would form our intersternal space, that sternal area would be suggesting about the midline on the anterior side. If these two are the mid-sternal point and the spine, if they are in the same alignment, then we say that the centering is proper. If not, if there is a slight displacement, then again, the orientation of the structures could vary and there could be some erroneous reading. When once that is qualified, the next part is you will have to make out what we call as the cardiothoracic ratio. The cardiothoracic ratio is studied by having a ratio of measuring the ratio of the total thoracic diameter compared to the cardiac diameter, by which you can make out the abnormalities related to the cardiac sizes. So cardiothoracic ratio is measured by or is assessed by comparing the dimension of the cardiac shadow with the thoracic shadow, which should not be more than 2 by 3. Then the other aspects like the hilar areas, the structures are identified, and then you go ahead with the reading of the X-ray. Once this technical qualification is done, the further you will have to identify these structures, and of course there would be a difference in the male and the female. The breast shadows of the female would also mask the shadow, and hence these also have to be identified. That's about the basic issue as it. Now I will not waste more time on that basic issue. We'll directly go into the diseases of the respiratory system. And again, as I told you earlier, the pathology can be understood only properly in the X-rays if you have the idea of actual pathology related to the disease as such. And we will try to cover up at least a few of the commonly seen disorders. Among them, the first is the inflammatory pathology. Once the inflammation occurs in the alveolar tissue, the changes could be of different varieties depending upon the type of inflammation as well as the reaction of the tissues. The commonest form of the inflammation would be the acute inflammation, where there would be exudates, lymphocytic proliferation in the tissue as seen in the microscope. The fluid exudate, they tend to fill up the alveoli partially, so there would be some amount of air area, space for the air, as well as some thin layer of the fluid would be formed in the specimen which can be seen under the microscope. Now, when you take an X-ray in the image, these alveoli, because they are very small structures, they may not be seen independently. Instead, the fluid will be producing some opacity, mild opacity, and this mild opacity could be seen as small dots, small spots in the alveolar area, as you see over this area, and they are scattered. It's not that the whole alveoli is filled up, but alveoli, they are partially filled with that fluid, and hence you will see slight clear consistency, and this is technically called as mottling. Mottling is something like some seeds are there. So that kind of an appearance is typical of the bronchitis as such. Of course, along with that, there could be slight changes in the lymph nodes. Lymph nodes also may be slightly inflamed. Now, as the condition progresses further, these mottling may become more prominent, and their areas could be bigger, which suggests about a more progressive pathology. Or even it may be that fluid may be filled into some of these tubular structures, the vascular structures also. They also may show some opacity. And as the condition progresses further, it may even lead to thickening of the bronchial area, and the tracheal surface also may be slightly inflamed. Now, all these would be what we call as the common cold or common cough conditions, which are the bronchitis, which I would be considered as a kaphajakasa. The clinical symptoms of these conditions at least would be patient may have a mild or a moderately high fever, and the sputum is thick and scanty. When you auscultate, there could be crepitations. Crepitations are due to the movement of the air through that fluid layers at the alveoli. And in such conditions, usually we can manage the patients easily with Mrityunjaya, Tribhuna Kirti, Lavasudhamshana, considering as a Kapajak Kasa. And steam inhalation may be one of the options to ensure that the alveoli are emptied and then the sputum is clear. The air exchange would be better. Now, suppose this condition doesn't resolve at that, or the patient has progressed further in the bronchitis. Of course, textually, you do not have that kind of a categorization of bronchitis grades like. But what we see clinically is clinically you'll have many of such patients who might have taken maybe a cough syrup, particularly cough suppressant syrups having codeine. There would be a stagnation of the fluid in the alveoli, and this fluid would become increased. And I would consider, now this is purely my this consideration, I would considering these where you have more widespread fluid collection in the alveoli, and the opacity is more as a grade 2 the bronchitis, where the condition becomes more severe, the expectation becomes more. Clinical symptoms of fever also would be increased. So that's again another of the example. There could be even more thickening of these bronchial divisions, thickening of the tune. Vascular markings may become more thicker, which suggests of a bit advanced condition. I would say that it's advanced condition where the condition would be present more than a week. Expectoration becomes more thinner. Preparations may be widespread, more than half of the lung would be covered. This is the typical features of the Pitta Jakasa, where you will have the typical features of Urovidaha, Jwara, Vatrashoshihi, Akhyarditaha, Tikta Mukhatrashartaha, Pittena Pitlanumeta. The condition becomes more severe, and most of the times the cause could be a cough suppressant therapy, cough syrups, which are commonly used by people. Now, in this condition, because of the environment of Pitta, my discussion will be Mrityunjaya Arogya and simple Lagusudha Mishra may not be enough. I may add Makardhya to ensure that hardened or accumulated expectation is drained out efficiently. Steam inhalation would be one of the options. Soma Sava also is one of the options to ensure that there would be a better expectation. There could be one more of the sort of the pathology which may produce more clinical issues, where due to the inflammation there will be a bit of more of edema, and that edema may produce thickening of the bronchial wall, and hence at that condition patient may start having bronchitis. So initially in a typical bronchitis condition there would not be a bronchi. It would be only the crepitations which are heard, but if the tubular structures they become edematous, there will be more resistance to the air passages, and hence the patient may develop bronchi. And these conditions, of course, technically are not called as chronic bronchitis. It's a chronic phase. Technically, to call a chronic bronchitis, you need some other parameters like it should be persistent for more than 6 months and so on. The other changes which can occur in that progression of the lesion, longer duration of the lesion would be the lymph nodes may become more in number. Usually they are small and their opacity would be like their density would be not uniform. There would be a relatively irregular density. The core area of lymph node would have a higher density. Periphery would have a lower density, which is suggestive of an inflammatory pathology as such, which is also the recurrent bronchitis. And this is exactly the situation which is considered as a Vataja Kasa. In the Vataja Kasa, because of the obstruction to the passage, there would be the sounds which would be having rather the expectation becomes drier, and the quantity of the expectation becomes lesser. That bronchi, which is has mentioned as a Shushka Kasa. हृच्छङ्कमूर्ध उदरश्वार्शूली श्यामाननः क्षीणबलस्तरोजाः प्रसक्तवेगस्तु समीरणेन भिन्नस्वरः. That भिन्नस्wara, the sound of the ronchi is the issue, or the Charaka has described the same as the srotam samrudhyamarutah, where the srotas are blocked or obstructed due to the edema with kapha purvaka. There will be involvement of the kapha also. That's the exact perfect description of the edema occurring in the bronchial tree and then the obstruction produced. In such conditions, my prescription would be Shasakutara, Arogyavardhini, Makaradhaja, and Vasakarishta or Draksharishta. The duration of the treatment would be longer if for about a month. And there is always a tendency for recurrent bronchitis. The patient may tend to have these episodes repeatedly. In such conditions, to prevent further recurrences, I would prefer a longer administration of the Deepanapachana Aushadhi like a Kumari Asava. That's one sort of the consequence of the inflammation. Now, another form of the inflammation in the lungs, particularly bacterial or viral infections, which are very rapid, which tend to develop rapid, and based upon the pathological changes, it's named as pneumonia or pneumonitis. In the typical pneumonia, the amount of the fluid formed is more, and it is thicker, and it fills up the alveoli completely. When the alveoli are filled completely, that area behaves like a solid, and hence it is called as consolidation. Because of that solidification, When you auscultate, there would be increased resonance. The blood sounds would be transmitted more, and hence the resonance would be the vocal resonance, or maybe the respiratory resonance or auscultatory resonance also will be more. And the typically the bronchial breathing would be heard because the air doesn't enter into the alveoli. Air just passes through the tubes and then goes back, and hence that bronchial breathing is a classical feature. In a standard typical infective pneumonia, standard pneumonia, the changes occur would be having a sequential pattern. Initially, in the first week, the consultation is partial, and at that stage, there would be, if you take an X-ray, you will have almost a similar feature as that of a bronchitis, like the mottling would be seen. The solidification or the hardening would not be advanced. Of course, most of the times, in pneumonia, the area is limited to a lobe, and hence usually you call it as lobar pneumonia, or it could be segment, where segmental pneumonia, or so on. The anatomical area of the inflammation are limited, but the intensity of the inflammation will be more. And in the first 1 week, clinically also, patient would have a high fever, but hacking cough. The cough would not have more productive this expectoration. Expectation would lesser. Even there could be some amount of pain in the area because the inflammation reaches to the pleural surface. Pleural surface has a somatic sensation, and hence the patient may have the pain in the chest area. Pain also may be related to the respiratory movements also. That's the usual feature in the first 1 week. And if you take an X-ray at that period, you will not see something like a DIMS modeling, which is almost similar to that of the advanced bronchitis, but the only difference is there would be a clear-cut anatomical margin. The standard is consultation, the real consultation would be seen usually in the second week. When you take an X-ray in the second week, the whole area which has been involved, it may become more opaque. The borders are very clearly defined, either it's lobar or segmental, and the area would be having the perfect, almost a complete consultation where air shadows are nearly absent. By third week, there would be a spontaneous resolution, and during the resolution phase, the air again enters the expectation. Usually, clinically, at that period, second, third week onwards, patient would have more expectation. Clinical symptoms tend to get relieved, and the either it's relieved or maybe in a complication condition it may reach to the other lobes also. But usual the standard course of pneumonia would be having a 3 weeks course, and during that phase there would be liquefaction of these solid substances, and the patient would expect that out, and that is seen in the X-ray as a air entering into the alveoli, into the area, and you will see these air shadows in the consulted area, which is classical of a pneumonia as such. Of course, some more examples of the pneumonia. Usually at the end of the second week and beginning of the third week, a consultative area, and you can see the air entering in as you see in this X-ray. Or the consultation, which is limited to a segment. In the lateral view, the same consultation also can be seen much better, and that's how a pneumonia, standard pneumonia is diagnosed. I will consider this pneumonia as really the Tridosha Kasa. Of course, the Samhitas do not mention about the Tridosha Kasa, but the course of the pneumonia is exactly the typical feature of starting with the Vata Lakshanas. Then in the middle 1 week, second week, it's about the Pitta Lakshana, and the third week is about the Kapha Lakshana. Now, in Charaka Samhita, about the Kasa, it's mentioned in Charaka Samhita, particularly Kasa, Vata Kasa. Sapurvam Kasate Shushkam. The initial 1 week, there will be a dry cough, and that's exactly the first course. Then Tataha Sriveda Sashonikam. Then there could be a expectoration which could be even blood stain. So the course of the pathology is mentioned, though there is no specific mention of a Sannipathaja Kasa, but I would consider these as signs of the three doshas involved in a sequence, like starting from Vata, then the Pitta and the Kapha, and the clinical symptoms also are very much related to that. Treatment, of course, would be in the initial first week, I would always prefer Mrityunjaya Makadha LSM. By second week, because it reaches like Vishama Avastha, I would prefer Lakshminarayan Rasa and then Makadha Lexophimistram, Varistar, Somas, or such of the treatments. Of course, all the pneumonia may not be possible to be treated with our treatment alone. There could be some issues which may require the other supportive therapy like antibiotic therapy, and mainly if the patient has a high leukocyte count of more than 16,000 in children, pediatric conditions again because the condition becomes rapid, or other coexisting disorders which can make the issues complicated. That would be usually in a case of pneumonia, it resolves in 3 weeks. If a pneumonia doesn't resolve in 3 weeks, there is some other underlying pathology which needs to be investigated, and that becomes a challenge. Now, among those unusual courses of the pneumonia, unpredictable courses of the pneumonia, one is about the COVID-19 pneumonia, which of course the people it has become rather very popular. People know about it. The course of the pneumonia in case of COVID-19 becomes very rapid, and once the pneumonitis starts, now this is a sequence of the patient like started on 11th day, X-ray taken on 11th day, it's almost nearly normal. And by 14th day, his area of consultation is seen. Within 3 4 days, the whole lung, both the lungs are involved, and the patient has a fatal issue. That kind of a rapid growth is a rapid progression of the disease is a characteristic of the COVID-19 condition, where the usual protocol of the treatment may not be enough. Another of the condition of abbreviation of the pneumonia is aspiration pneumonia, very often seen in patients who are bedridden and who are not able to swallow, or patients having neurological deficits, or unconscious patients. If there is an aspiration of the contents into the lungs, that again usually it's limited to the right lower lobe. You may because the substances pass through the right bronchus easily than the left bronchus, and the area of consolidation also would be limited to that area and tends to become rapidly progressive, which may not be amenable to the usual course of the treatment. It tends to get prolonged, complications are more, and the treatment protocol would be more detailed. Then another of the variation of the pneumonia is a hypersensitivity pneumonitis, or due to the allergic pathology, where the usual course, as I said, about 2 to 3 weeks or 3 weeks course may not be visible. Instead, there could be a precipitation of the consultation when the patient is exposed to the allergens, and it also can result in what we call as eosinophilic pneumonia, where the lobar distribution of the lesion may not be very accurate or may not be very clearly defined. It could be haphazard consultation, and this also requires a different sort of the treatment. The same protocol of the treatment may not be enough. That's a variation as such. There are certain conditions where a plain X-ray may fail to diagnose the pneumonia, particularly in old aged patients. Clinically, the symptoms may be suggestive of pneumonia. X-ray may not show because X-ray is comparatively less efficient. Plain X-ray is less efficient to make the changes, identify these changes. You may simply make it like a pneumonitis, simple pneumonitis, but in a CT scan, it could be better. So there could be some situations where you may have to go for the CT scan, the next advanced conditions. Another of the complex issue which would be really challenging in the clinical practice would be a underlying lesion which makes the pneumonia complicated. Patient may initially have the same clinical symptoms as usual of pneumonia, but there could be a failure of resolution. Condition doesn't resolve with the usual treatment, and either it may progress in the same manner or it may worsen. And in such conditions, there could be some other underlying pathology, either tuberculosis, tumors, etc., and so on, which need to be investigated thoroughly, and which is a real challenge for the clinical practice, where all series of battery of investigations may be done, and still there could be some situations where the real underlying pathology still is not diagnosed, but the patient may have more serious complications. Again, more detail about that underlying pathology, I just skip that part. Now, one more of the confusing area in the reading of chest X-ray, particularly in the consolidatory pathology, the causes of the consolidation. Consolidation is, in the sense, the alveoli becoming opaque in the X-ray. may be produced due to many other causes, not only due to the pneumonia, and it's absolutely necessary to differentiate. A typical pneumonia produced consultation would be gradually progressing with the alveoli filling up with the fluid, and the opacity becomes having a anatomical demarcation. A consolidation also can occur due to a hemorrhage, bleeding into the lungs, where the blood will flow into alveoli, and the focus of that bleeding would have more higher density opacity. The blood at some areas where there is a bleeding would have a higher density of opacity, and blood also would be more opaque to the X-ray than simple the expectoration, and the area would be haphazard. And this kind of appearance is more characteristic of a hemorrhage. A pneumonia which becomes typically consolidated at the end of a second week. That's what we can make out, which we have already discussed part. Then a infarction, a pulmonary infarction also may produce a opacity, but in a typical infarction, the size of the lung tissue becomes reduced. It's also that some of the tubercular lesions also may produce a consolidation. In that condition, there will be size of the lung tissue should be reduced, and hence when you see the plural line, there would be some space reduction. As you see over the lower lobe, there is opacity, and that opacity has resulted in a relatively gap between the thoracic cage and the pleura. This is either suggestive of an infarction or a fibrosis, which results in the formation of which looks like a consolidation. Then it also consolidation also can occur due to the vascular edemas, like cardiogenic pathology. Congestive cardiac failure, what we call as a pulmonary hypertension, also may occur in such patients. The edema would occur, but in these cases, again, that it will be always gravitational dependent area, and by that, in all such conditions, because of the gravitational force, the congestion would be more in the gravitational dependent area. So if you repeat the X-ray in some different positions, that can be made out. Moreover, the density would be more in the lower area, and towards the gravitational superior area, density becomes lesser. And the anatomical markations also may not be very clearly seen. A consolidation also can occur due to conditions like sarcoidosis or fungal infections, where there will be a patchy consolidation. A tumor also can present with the consolidation, which will be heavy, dense lesions as such. So that's about the pneumonia and its variants from the clinical point. Now, one more of the condition which can be a consequence of the infective pathology is the same infective pathology may become more chronic, and it may produce a damage to the lung tissue, and alveoli may become flattened and dilated due to the infective pathology. The surface of the alveoli may become thickened, and this may produce what we call as a beehive-like appearance in the lungs. The lung becomes again having some spot, wider cavity-like, and that condition is called as a uh, bronchiectasis or honeycomb appearance or beehive-like appearance is seen. Microscopic evidences also would be confirming the same. The dilated bronchi, the bronchioles would be dilated. The surface would have a thin layer of fibrous tissue. Mucosal surface would have a thin layer of fibrous tissue, and there would be huge amount of the exudates. Proliferation of the uh, leukocytes also would be more. Now, in a chest X-ray, these changes are seen as what we call honeycomb appearance. Typically, these dilated alveoli with that thickening layer, it's just exaggeration of the normal alveolar pattern is seen in these conditions, and this is exactly what you see. The fibril layers also could be seen. Of course, in this X-ray, there are some more additional features of a cavity, but in this X-ray, the bronchiectatic changes are seen in the superior area. Of course, there are some more fluid-containing cavities in this X-ray, which is a sort of a different pathology. There is a mixed pathology, but at this present situation, when we discuss about the bronchiectasis, we will focus on this area. These cavities, of course, I will be discussing about the cavities later on. Thin-walled cavities, which are often suggestive of secondaries in the lungs. Anyway, a typical bronchiectasis, where the lesion could be widespread there, and because of that thicker fluid and widened bronchi, you will hear coarse crepitations, which are mentioned as leathery rails, very loud rails as such. And this is exactly what you see in case of the Kshatrika Shabdata cancer and the typical clinical symptoms of a bronchiectasis developing is a purulent expectation or mucopurulent expectation. Quantity would be more, and more important would be postural. The patient would have more expectation when he lies down on the other side. So that because it tends to flow freely, and once the expectoration is brought out, patient would have some relief. So that's one of the characteristic clinical signs, as well as the course level crepitations, Lillary rails also would be the other sides. Many times, a patient of bronchiectasis may have an underlying pathology like rheumatoid arthritis, cystic fibrosis, HIV, etc., which needs to be ruled out. And these are typically described by the Kshatraja Kasa, where though the trauma is one of the causes mentioned in some other than that, the features are exactly Vitam, Shavam, Shushkam, Gratism, Kuchism, Bohu, the equivalent expectation. Stevens container Vinyana Chagrasa, Suti Vivatikshna Bhityamanana Shulena. The typical features of that is mentioned in the Kshatrajakasa. The course of the treatment in case of bronchiectasis, of course, it's a palliative condition. There is no question of complete cure anywhere. The bronchiectasis can almost a condition which cannot be cured, but only can be managed to a certain extent. And effective palliative measure, compared to the contemporary situation, from our early point of view, the clinical symptoms can be improved or relieved to a great extent. A patient can have a comfortable life. And my usual prescription would be Mrityunjaya Swarnamalini Vasanta with the Lavsuta Mishrana, which is given regularly. Then expect kashayas like Vasakasava or Somasava or Draksharishta could be given. Postural exercise also is one of the issues, important issue. Pranayama produces a significant change. Virechana also can produce some changes in the course of the disease if the patient is fit. Virechana can be given in a fit patient where the course of the disease can be modified to a great extent. Now, one more of the condition which I would be discussing would be tuberculosis. Now, tuberculosis is a specific disease entity produced to the organism, I know about it, which may produce granular matters infection. The pathological changes produced due to the tuberculosis also would be quite wide varying, particularly in the lung condition. Initially it starts as the primary, which is involving the lymph nodes, and then of course it spreads to the other area. The important lung lesion would be the caseating lesion, where there would be a granuloma, and the granuloma is having giant cell layer, and in the central there is a caseating substance. And that's what we see as the first of the changes in a typical tubercular granuloma. And in a primary in sense, a patient who is not exposed to the tuberculosis earlier and for the first time has the tuberculosis, the area of exudates will be more. Whereas in a post-primary, that's a patient who is already exposed to the tuberculosis, the area of exudates will be lesser. Then gradually it results in more of fibrosis, and that fibrosis will be producing a lot of changes in lung tissues. Either the tissues may become hardened due to the fibrosis, or the central area may become necrosed. The caseating substance may become sloughed out, resulting in cavities. So, in a gross tuberculosis lung tissue, you may see the areas of fibrosis where the lung becomes hardened, and within that there could be some empty spaces, or a simple cavity could occur, or there could be just the density of the lung tissue could be increased, and so on. So there could be multiple varieties of the lesions. From the radiological point of view, from X-ray point of view particularly, the changes produced with the tuberculosis are again classified as primary tuberculosis and post-primary tuberculosis. Primary tuberculosis in our setup is comparatively rare because most of the people are already exposed to the tuberculosis, and inoculation, BCG vaccination almost is a rule, and hence almost all the adult patients of tuberculosis which we get would be having the post-primary characters. Whereas rarely in children, or very rarely a few of the patient may have a primary tuberculosis lesion. And the typical clinical, these radiological evidences could be either a consultation, parachemical consultation in the usually lower zone and in the subpleural area. Now, I'll show you some examples of these. So, each of these examples, or it could be simply a lymphadenopathy, or there could be cluster parenchymal opacification, or a pleural effusion, or a miliary tuberculosis also may be seen occasionally. I will show you the examples of these, what we mean by that. Post-primary tuberculosis, which we see quite frequently, again from the radiological point of view, we categorize them as a parenchymal disease, airway disease, or pleural disease based upon the area involved. Of course, in a typical patient, you will have all the three areas involved. Majority of the patient would have all the three involved. But for the purpose of studying these abnormalities, we categorize these parenchymal, airway, or pleural changes. In a parenchymal changes, there could be ill-defined patchy lesions or cavitations could occur. And majority of the patients whom we see in the adult and in the clinical practice, they come at that stage where the patient may have a cavity. Or it could be endobronchial spread where there could be a nodule in the central area and the lung, bronchi, they may be partially dilated, partially constricted, which is also called as a key in but opacities in the X-ray. Or there could be a parenchymal opacification, which may produce a satellite like multiple lesions, which is also called as galaxy sign, which is seen. Lymphadenopathy occurs in only 5% of the post-primary lesions, whereas primary lesions, the lymphadenopathy is more common. And healing, another of the majority of the other group of the patients whom we see would be having patients who have either healing or healed tuberculosis with the fibrocalcific disease changes, and hence there would be reduction of the volume of the lung tissue and a compensatory displacement of the structures, which is more common. So, majority of the patients of tuberculosis whom we see in clinical practice either are at the cavitation stage or at that stage where there could be a fibrocalcific disease which results in volume loss, or then the complications of that like bronchiectasis. Then the airway involvement would produce a bronchial stenosis, which is also quite common. Or there could be a broncholytic opacities in the bronchial area, which can produce some thickened, fibrous, harder substances. Or a bronchiectasis, which is again as a consequence of the traction or this displacement, or mucoid impaction, not so common. Pleural disease, another group of the patients whom we see would be having the pleural effusion. Either it may be, of course, uh, as per the data, pleural effusion occurs in 18% of the patients of tuberculosis only. But when you see a patient of tuberculosis in our area, because tuberculosis is endemic, the 80% of patients with the tuberculosis patients of pleural effusion are tubercular. Even that effusion could be having a pus-like consistency. Now that whether it's a pus or other fluid, that has to be made out with the only after the paracentesis. If the only after the fluid is drained out and examined, you can make out whether it's really pus or otherwise. Or the other way is a pleural thickening and pleural calcification. Now I'll show you some of the examples of these. A typical primary tuberculosis presenting with the lymphadenopathy, usually seen in children, where you will have a lymph node again, the appearance of lymph node in a tubercular pathology is very classical. The density of these lymph nodes are more, the shape is almost perfectly spherical. The core area of the lymph node would have a lesser density. Peripheral area of the lymph node would have a more density, which is the characteristic of a tubercular lymphadenopathy. Of course, to confirm whether it's really tubercular or not, you need to have the other investigations like biopsy or maybe so on. So it's not that only with the radiological evidences you make the diagnosis of tuberculosis. A simple X-ray alone is not enough to make the diagnosis of tuberculosis, though it may give sufficient clue as well as it can give you some idea about the progression of the disease. Now, one more of the feature which is seen in primary lesions are these consolidations, patchy consolidations at the area. Again, unlike that of a typical pneumonia, these consolidations would not have a typical pattern. The bronchovascular markings also would be thickened haphazardly, and hence you see linings which are not parallel to the ribs. In a typical vascular marking, the typical normal vascular marking will be more or less parallel to the ribs as such, whereas these fibrous markings would be haphazardly arranged due to the suggestion of the fibrotic changes which occur. Some more examples, the higher density lymph nodes which are very much calcified, usually very chronic tuberculosis, dense calcification, and the fibrotic band seen in some of these X-rays. So some of those X-rays. Then a cluster opacification, which is also called as galaxy set, multiple spots of opacities which are seen, and some of these opacities may show early signs of cavitation also. These are the signs of cavitation. But these haphazard opacities also could be a sign of tuberculosis, and because they are looking like a star in the sky, the usual name given is a galaxy sign. Thickening of the pleura also could be one of the feature. Sorry, now there is one issue. This detail about the quantity of the fluid is related to the pleural effusion. See, thickening of the pleura could be seen as a opacity. Now, whether there is a really fluid or not, it cannot be easily made out with the plain X-ray. So, with the plain X-ray, when you find a opacity, you may say that it's a pleural thickening, but whether it's a fluid or not would depend upon whether the costopleural angle is obliterated or not. If there is a fluid, the costopleural angle would be obliterated, whereas if there is no fluid, it will not be obliterated. That is a usual rule. But still, there could be many exceptional situations. Fluid can be better made out only when, or better made out with the ultrasonography. The normal quantity of the pleural fluid is less than 5 ml. Many times with a perfect ultrasonography, even that can be identified. Whereas by plain X-ray, the least quantity, the smallest quantity of fluid which could be identified in a plain X-ray would be 50 ml in a lateral chest radiograph, and that too if it is perfectly taken. In an anterior posterior X-ray, the least quantity, smallest quantity which can be identified easily is 200 ml. So if the fluid is up to 200 ml, then only a plain X-ray may show that obliteration of the cosopenic angle in the anterior posterior view. If it is less than that, it cannot be made out. So many times we may make a assessment that it is a pleural thickening, not the pleural effusion. But when you put in the needle and then aspirate, you'll know about the fluid situation. So in such a condition, ultrasonography could be a better investigation as such. Then if it is 500 ml, that's if one segment of the rib is obliterated by the fluid shadow, then it's considered to be 500 ml. That's how the quantity is assessed. Now, some more example of the fluid effusion. Now, here in this X-ray, the pleural thickening is very marked, but in the lateral view, costophonic angle is absolutely normal, and hence we consider this as a simple pleural thickening without much of the fluid, which also is typical of the tuberculosis. The costophonic angle obliteration is the most important issue in case of assessing the pleural efficiency, uh, angle or costopleural angle. This area, costophonic angle, where you find the opacity is a sign of the fluid pleural effusion as such. Some more examples of the pleural effusion. It could be of a quite wide extent, and a untapped pleural effusion where there is no air and fluid interface would have somewhat a oblique margin, S-shaped margins or curved margins as such. It could be very extensive, and when the effusion is more, it may push the structures to the opposite side. The pericardium is pushed to the opposite side. Displacement to the opposite side will help you to differentiate it from either a consolidation. In a typical consolidation producing the opacity, there will be no displacement of the structures against. Whereas in a effusion, the structures would be displaced to the opposite side. Even at times, it could be seen as a increase in the gap between the ribs. The intercostal space may also may be slightly increased on clinical side. Of course, clinical evidence of the pleural effusion will be a dull sound on percussion with as the absent blood sounds. Once the fluid is tapped, now, in this X-ray, of course, that displacement is quite obvious, visible in the first X-ray. Once the fluid is tapped, there will be a fluid and air interface. The air enters in, and if there is a fluid and air interface, you will find the horizontal line. Whereas in a typical untapped effusions, the lines would be oblique as such. That's about certain of the variations. As I told you earlier, the ultrasound would be always much more efficient, and a perfect ultrasound can even identify the normal fluid 5 ml, whereas a minimal volume of 20 ml also is reliably detected. When the quantity of the fluid is 100 ml, the ultrasound is 100% sensitive. So, in such suspected ultrasound for these effusion conditions, ultrasonography is better. That's one of the pleural effusion and pleural thickening are one of the changes which we see in case of the tuberculosis, both primary as well as secondary. Now, another of the condition which is seen more frequently in primary tuberculosis is miliary tuberculosis. Miliary tuberculosis is due to a sudden rapid development of the course of the tuberculosis, where there would be a rupture and the hematogenous spread of the lesion, and hence a wide area of the lung tissue is involved, and you will find very multiple spots. As if some grains are spread over, is just an exaggeration of the mottling seen and widespread areas seen. That's what we call as the miliary tuberculosis. Then consultations could be again of different conditions, particularly post-primary. A consultation which may be seen as a patchy lesion without any cavity in the initial stages. You may see consultation which is patchy. Unlike that of a typical pneumonia, you will not have the typical markings. And of course, in a good number of patients of pneumonia also, there could be underlying tubercular pathology, and many times only when the primary pneumonia is treated with the usual course of the treatment, the underlying patchy lesion could be seen, which may be a cause for unresolved pneumonia. The patchy lesions may gradually progress into cavitation. The caseating substance in the center may become cavitated, so you will have some of these empty spaces. Here also you can see some areas where the air tends to fill into that gap of the consolidations, and that's how it results in cavitations. Cavities in the lungs could also be produced due to other lesions also, other causes also. And it's important to differentiate these as far as possible. Though the differentiation based upon the X-ray may not be absolutely accurate, there is a need for other investigations too. To a great extent, we can make out the difference between a cavities produced due to tuberculosis and other lesions. Typically, a tubercular cavity would have a smooth surface inside. The outer surface of the cavity would be thick and infiltrating. The outer border will be penetrating or seeming to be infiltrating as let's say typical of a tubercular cavity. The reason is simple. The inner surface is having a granular layer, whereas the outer surface would be having that fibrous tissue. That's the exact pathology of tuberculosis. Of course, in this X-ray, there is an area of consolidation, patchy consolidation with the cavities on the other side. In this area of the cavity also, you can make out the same feature. The inner surface is smooth. Another example of the tubercular cavitation, progressive cavitation, where you can see the cavity here in a medium of this consolidation, and that area would have a smooth surface as such. One more example, typical, the thick-walled cavity. Now, these thick-walled cavities also could be produced due to other reasons. Uh, a necrosis of tumor pathology also can produce a similar lesion. So, when you have a thick-walled cavity with a smooth inner surface, outer surface being irregular, tuberculosis, of course, is one of the important issue. Whereas tumor pathologists also have to be considered as other possibilities. Whenever there is such a suspicion, a lateral view X-ray can help you. Tuberculosis usually is limited to one segment, like at the anterior or the posterior. In the lateral view, now the lesion is limited to the anterior surface of the chest, and hence we may suspect it to be more of tubercular origin. Whereas a tumor pathology which may produce a cavity, it may be involved in both the surfaces, somewhere in the middle of the lung tissue would be located. Now, another of such a confusing X-ray where the lesion could be either tubercular or another way. Another important difference in this cavity is the inner surface of the cavity is somewhat irregular. The outer surface is having somewhat regular feature, which is suggestive of a non-tubercular abscess, purulent abscess which has got drained out, a abscess which gets drained out, and then later on the lung pulmonary abscess can also result in the cavities. A pulmonary abscess may be presented in the acute stage with the segmentations. When you have this cavity with the segmentations, it's a typical of a pyogenic abscess in the lung, which is not tubercular, which has to be made out. The cavities, abscess cavities in due course of time, once the abscess has occurred, even if it is cured and treated at that moment, the cavity may remain and the cavity may be a cause for the fluid to be accumulated. So multiple fluid levels could be seen in a cavity, and that makes suggest about the bigger size of the cavity, and the exact identification of the pathology would be difficult because whether it's really a primarily purulent, whether it's tubercular, or whether it is of malignant origin, it would be confusing. Usually, multiple cavities are more frequently seen in tubercular than other lesions as such. But of course, pulmonary secondaries, canal wall appearance lesions, they may present with the multiple cavities. Now, thin walled cavities, cavities having a thin wall is characteristic of multiple secondaries. Now, these are the two X-rays of the same patient taken in a gap of 3 months. So initially, the first X-ray had shown one single cavity. Within 3 months, this patient had multiple small thin-walled cavities. These thin-walled cavities are very typical of the secondaries in the lungs, and most of the times the primary would be in the kidneys. A primary in the kidney resulting in secondaries in the lungs would be presenting what we call as a cannonball appearance, where multiple, almost perfectly circular lesions looking as if the area is punched out, the lung tissue is punched out. That kind of appearance is seen in such conditions. A primary cancer of lung also may become cavitated, which is usually presented as a hard mass, and then there is a necrosis, and the necrosis would occur. The typically a typical cancerous mass of the lung tissue would be having a irregular border, a irregular patchy appearance, and that's how it is seen in such conditions. A rare condition which we see often is a fungus bone cavity. Of course, most of the times when you have a fungus bone cavity, the patient would have a severe immunocompromising condition like HIV, or patients who are on radiation therapy or chemotherapy for some other malignancy may develop these issues. And these fungal ball cavities are typically having an irregular shape, density. There may be a fungal ball. The central area may have a opaque ball-like structure, which is characteristic of the fungal cavities. That's also is seen. Of course, a thick-walled cavity with the displacement, because there is a fibrocystic pathology also. The trachea is displaced to the other side, the area of the cavity. So there is a cavitation along with the shift of the structures, which also could be a presentation of the tuberculosis. The other presentation of the tuberculosis is what I got as a three input opacities. The opacities which are hepatocyclic, the bronchial structures, markings would be enhanced. Of course, a plain X-ray, it's very difficult to differentiate these, but whereas a CT scan can make out that image, the tree in but appearance very classically, as you see the thickening of the bronchial tree with the presence of wider spaces in between, a magnified view of the same is seen. So that tree in but changes of tuberculosis are better made out with the CT scan, whereas in the plain X-ray, it may be just seen as a irregular patchy opacities. A parenchymal opacification with the satellite lesions, multiple opacities, also can be a presentation of tuberculosis. Of course, incidence wise, this is less common, and it may produce a radiological confusion with the pneumonitis in many of these patients. Again, patchy lesions, when they become very prominent, hepatocyte patchy lesions with cavitations, that confirms the tuberculosis as such. Then lymphadenopathy alone also could be a sign of tuberculosis, but they are seen only in a few of the patients, like 5%. And I think I have already discussed about the characteristic feature of a tubercular lymph node, where the density would be uh, rather more towards the periphery than the core area. Then fibrocalcification disease, where there could be calcification and fibrous changes would occur with the compensatory displacement, the trachea being shifted. Now, because the lung tissue has become fibrous on the left apex, the trachea has become shifted. Shift of the trachea, shift of the mediastinum towards the left side. or shift of the diaphragm having that tenting effect seen also is one of the characteristic features. Now, these displacement could be very severe, producing a very huge asymmetry in the lung tissue. Multiple folds could occur in a typical tubercular displacement. And as I told you, these are the more common varieties of both tubercular pathologies. In these patients, the tuberculosis need not be active. Patient may have these secondary complications like infective pathology, bronchiectatic changes could occur. Patient may have significantly reduced volume of the lung, resulting in dyspnea and exertion, and the patient would be really suffering in such conditions. A tuberculosis also can result in a pneumothorax, a blockage. Some of these bronchi may become blocked and or maybe ruptured, lung tissue may be ruptured, and hence there could be air filling into the pleural space. The whole lung tissue may be displaced to the other side. That kind of changes also rarely may occur, or it could be a huge displacement, a very huge displacement due to the tuberculosis also can occur, extreme cases of that sort. The broncholids, calcifications within the bronchi presenting with that stone-like appearance also could be a evidence of tuberculosis. Incidence would be comparatively lesser, but still they could occur. Pleural thickening, of course, may be very marginal. Pleural thickening we have discussed, but this is one of the conditions where it could be very marginal and the surface would be having that irregularity. And these would be having a confusion with the malignant changes, the wart cell carcinoma, the involving the pleura in the beginning would present with a similar feature. As well as that, once you have made the diagnosis of tuberculosis, as I told you, the tuberculosis diagnosis cannot be made out only with the single mode of investigation. Multiple mode of investigations would be necessary to make the diagnosis of tuberculosis. And the protocol of the treatment now, as per the current government this guideline, every patient of tuberculosis should be reported in the Xray website. Otherwise, it can become an offense. So essentially, once the diagnosis of tuberculosis is made, it's mandatory that you have to report the case in the Xray website, and the treatment is a responsibility of the administration. The medicines are given free of cost. The patients also are given some incentives, cash incentives to maintain. So, from Ayurvedic point of view, I would not now consider any tuberculosis patient as treated with the early Ayurvedic medicine, but there could be a supportive treatment either during the course of the treatment of tuberculosis or later on after the course of treatment of tuberculosis is over. The patient may have continued complications due to that fibrotic changes and the structures displacement. They can be improved upon. Their clinical condition can be improved upon with the usual supportive treatment like Magaravadaya Lagusudha Mishra, Arogyavardhini Kumariyas or Draksha Vishra to take care of the nourishment of the patient, Rasayana therapy with the Chavanaprasha, and in the patients who have a multi-drug resistant tuberculosis, where the other drugs would fail, a better palliative treatment would be Vishamajwara Chikitsa, like Dharthaka Jwara Chikitsa, Lakshmi Narayana, Rasa, Arogyavardhini, Makaradvaja, Abhrakavastam, Sitoplasty, and Vasakarishna are the usual treatment. Now, one more of the consequence of an inflammatory pathology of the lungs is the chronic bronchitis. Chronic bronchitis is defined as a condition which presents with an obstruction to the passage of the air and which is persisting for more than 6 months, doesn't usually resolve due to our usual conventional treatment. The changes which occur in the tissue, microscopic changes, would be having multiple issues, like either there could be mucus gland enlargement, these glands would be enlarged as you see, and goblet cell hyperplasia, the goblet cells, the round cells over here, they become hypertrophic, epithelium becomes inflamed, the cilia, the other important issue is chronic bronchitis, is the cilia which tend to expel out the sputum, they become non-functional, and hence there is always a tendency for the stasis of the expectoration. The smooth muscles of the trachea, they become hypertrophied, this red layer, horizontal layer. It becomes hypertrophied, and the bronchial wall also become thickened. These are the changes, microscopic changes which occur in the chronic bronchitis. Radiological changes seen in a chronic bronchitis again could be of many varieties. The most important is the lung tissue markings are reduced and there could be a increased density of that. which is also called as emphysema. So emphysema changes, decreased lung markings, and there would be hyperlucent lung tissue. Or there could be the reticular markings. There could be fibrous bands, irregular fibrous bands seen in the area, and which also could be the other issue. Shape of the chest tends to be altered due to that reduced capacity of the lung tissue to take in air, and hence the shape of the chest becomes barrow shaped. Or diaphragmatic surface also become irregular. That could be folds of the diaphragm, or the trachea may be somewhat curved, which also could be the some of changes which are produced due to the chronic bronchitis. I'll show some of the examples. The diaphragmatic variations, irregularity of the diaphragm, the fibrotic bands seen, irregular fibrous bands seen in a typical of chronic bronchitis, or it could be emphysema changes, the air locked in sign where there could be multiple areas of increased density, and the air density is more, and the fibrous bands in the diaphragmatic surface become irregular. That's also a sign of chronic bronchitis. Or chronic bronchitis may present with a patchy lesion, widespread fibrotic lesions seen at the area also, which could be the issue. From the Ayurvedic point of view, these bronchitis conditions again could be of two categories: obstructive or restrictive. See, obstructive is see, of course, consequences of the chronic bronchitis are either due to the obstruction to the passage of the air in the bronchioles that the patient would have symptoms, or the later on in a case of emphysematous conditions, the total volume of the air which can enter in can be reduced, and that's what we call as restrictive. Rather, from the point of view of this clinical assessment, whether the obstruction to the lung tissue or the air passages is the most important issue for the presentation, or whether it is the reduced volume of the lung tissue is the most important issue, which can be made out. Of course, spirometry can help you to make out that difference, and the treatment protocol also can be slightly modified. Now, a typical clinical presentation in both the conditions will be exercise intolerance, breathless presented when the patient doesn't exercise. If you auscultate carefully, the gap between the first and the second sound, or inspiratory and expiratory sound, can help you to make out the diagnosis to a extent, though spirometry is the standard benchmark diagnosis. The obstructive pathologies are usually the chronic bronchitis, which is also called as COPD, emphysema, or cystic fibrosis. Restrictive, they are named as interstitial lung disorder. In addition to these interstitial lung disorders, a restrictive pathology also can occur due to obesity, structural abnormality of the thoracic cage. Patients who have neurological diseases also may have a restrictive pathology. The interstitial lung disorders are seen in X-ray as a presence of increased density of these vascular markings seen scattered throughout, and the changes in the shape of the chest cage, the total lung tissue volume may become reduced. These changes would be seen in the periphery also. That would be the radiological evidences. Interstitial lung tissue disorders, these increase in the density of these vascular markings would be seen in a typical lesion of the lung tissue, which is also named as a COPD. Now, this COPD, asthma, and so on, these words are often misleading issues. And these interstitial lung tissue disorders also could be presented with a prominent hilar shadows and extended shadows of the bronchovascular markings, which are seen. These are the typical radiological evidences of interstitial lung disorder. A interstitial lung disorder also can present with the cumulative exudates, the dense mottling, which mimics the miliary tuberculosis features, but clinically you'll have to rule out that that kind of an appearance also could be seen in case of a interstitial lung disorder. Emphysema is a locked air sign, which also is a consequence of the same the lung tissue pathology, where the patient would have a alveoli which has become flattened, and hence the air becomes locked in. The density of the air would be more. The typical vascular markings may not be seen as such. It looks as if it is a air-containing balloon-like appearance would be seen, or there could be even a partial collapse of the lung tissue, which is called as aterectasis. The displacement of the area, collapse of a lung lobe also could be a consequence of same, which can result in a restrictive pathology. These also become restrictive as such, or a gross fibrosis and multiple emphysema in area, fibrosis in some areas, The atelectasis in some areas, the lower lobe, left lower lobe atelectasis. So multiple issues could occur in a patient with chronic bronchitis, and clinical severity also would vary. Now another more complicated issue, there is a emphysematous changes, the fibrosis, atelectasis in the left side, uh, almost all the changes are seen. These kinds of patients do occur present with the very chronic history as such, and the treatment protocol would be almost same for all the patients. Of course, the outcome would be poor in such conditions. Now, a relatively less common conditions otherwise would be pneumothorax, where the patient may have air entering into the pleura, which also could be a consequence of the peripheral trauma or due to multiple underlying pathologies that the lung tissue may rupture. So, diagnosis of a patient in the case of tuberculosis would be always difficult, or rather, it should be more elaborate. Uh, Clinical signs would be hyperresonance and reduced breath sounds, which also could be signs, and there the treatment would be if there could be a tension pneumothorax, if there is a displacement of the mediastinum and cardiac distress, which is a immediate emergency where you will have to create a opening otherwise and convert that tension pneumothorax into a open pneumothorax, which is again a very critical issue. But from the clinical point of view, they are less common, but they produce a challenge to make the exact causes of the pneumothorax as such. Now, in all these conditions, our treatment protocol would be in all these restrictive conditions, the treatment protocol would be has to be ಶ್ವಾಸಕೋಶರ ಆರೋಗ್ಯವರ್ಧಿನಿ ಪಿಪರ್ಯಾಸವ ಆರೋಗ್ಯವರ್ತಿಗಳ ಚೂರ್ಣ because the shwasa is related to the anohotsosis or amashodbhavam condition. And these are the typical descriptions mentioned in the Samhitas of Urdhva Shwasa and Shudra Shwasa, where the patient would have the dyspnea and exertion. One of the important issues is pranayama helps significantly. Virechana also could be useful in a fit patient. That would be treatment protocol. The last part of the discussion would be about the tumors, lung cancer. The X-ray findings of the lung cancer also could be quite varied. It could be a single nodule or with the speculated borders or cavitation, consolidation or effusion also, pleural effusion also could be presented, or it could be mediastinal widening. Of course, to make the diagnosis of lung cancer, the plain X-ray has a very severe limitation. The accuracy of this diagnostic process is very low, and you need to have the other investigational tools like MRI scan or bronchoscopy to confirm the diagnosis of lung cancer as such. I'll show you some of the examples. The nodular lesions, small nodules. In a typical nodule of a cancer, the surface would be consistency will be irregular, borders also will be irregular, and it's quite difficult to differentiate these from the other lesions. Often need lot of experience. A nodule, when it becomes a Hephaesar or bigger, and it is located elsewhere other than that of the hilar area, of course, it becomes somewhat easier. The consistency could be very opaque, and when you find an opposite of that sort, it would be diagnosis of a tuberculosis, these neoplastic conditions. Very huge nodule in the hilar area with the irregular consistency also is more typical of a tumor pathology. Again, the exact type of the tumor, whether it is a lymphoid tumor or lymphomas also can present with the similar appearance, which needs more elaborate clinical assessment. A typical wart cell carcinoma, where a carcinoma which presents with a huge ball-like appearance with the dense opacity, it's very classical of the condition of tumor pathologies of the lungs. So, diagnosis of a lung cancer is made out. Or lung cancer can present with the other complications like a pleural effusion. These multiple nodular extensions or even metastasis within the lungs also can occur in such conditions, which would suggest of more advanced conditions of the lung cancer as such. Or there could be multiple opacities. These multiple opacities are maybe sign of secondaries in the lungs. Now, among the tumors of the lungs, the secondaries in lungs are more commonly seen in our setup than the primary, and these are the typical secondaries which may later result in what we call as the cannonball appearance. Mediastinal thickening is another of a troublesome issue in the radiological practice. When a patient presents with the thickened mediastinum, all that what we can conclude could be either there could be a lymph node enlargement or there could be aortic abnormality of the aorta, which need to be differentiated, which is quite difficult from the clinical, this simple plain X-ray. It needs to have a elaborate investigation follow-up. But tumor of the lung also can present with the wide and mediastinum as such. Some of the examples are the tumors of the lungs presenting with the mediastinal widening. Either it could be a huge mass with the globular appearance or a flattened multiple masses, accumulated multiple masses, which could be seen in the X-ray, which also could be sign of tuberculosis. Now, these can mediastinal widening, the causes could be better made out by a CTR, MRI, and then the diagnosis would be helpful. Or there could be metastatic lesions. Usually, there are multiple. A typical cannonball appearance, which is produced due to the primary in the thyroid. Now, this patient had a primary in the thyroid and the secondary in lungs, which are more opaque as such. Now, lung cancer is one of the troublesome disease. It's one of the leading cause of cancer death. Prevalence also is increasing. As such, survival rate is very low in case of lung cancer. And in India, the lung cancer rate is much higher. It's around 6.9 per 1 lakh population. And hence, from the clinical point of view, we have to be very careful in making the diagnosis. I don't suggest that we can cure a case of lung cancer, but palliative treatment can be helpful. With this, we'll come to the end of this session. The important points are for a successful clinical practice, you have to have a proper investigation tool, and it's quite important to know like which of the investigation tool would be relevant in that particular condition. Then only it will be meaningful. Chest X-ray is an important diagnostic tool with its own limitations. I think I have referred to some of those limitations. Investigational tools can help in fine-tuning Ayurvedic practice also. It's not that the X-ray is not mentioned in Ayurveda, and there could be many people who say like, "What's the X-ray in Ayurveda?" But still, we can make out and fine-tune Ayurvedic prescription. With this, I will conclude today. And if there are any questions, I will try to answer them. And I would expect this feedback as such. If there are any questions.
Thank you for such an informative session, sir. Yes, ma'am.
Thank you, Doctor, so much. I always enjoy your lectures, and I have listened to many of them uh, on WhatsApp. I just want to know, in case some patient wants to contact you, is that number 98451508822?
Okay, for contacting for patients, I'll give you a different number. It's not the same. It's my personal phone number, which I generally don't. That's a WhatsApp. Maybe WhatsApp message is fine, but if they call, I may not be able to read it. But if at all anybody is interested in contact me, I will give a different number. Or
Yeah, if
email
you can
ID
give
is
us a
better.
number where they can fix an appointment with you, that would be very nice.
Email ID is better. Okay, right.
Email ID is better. Okay, thank you so much.
Right. Right. So we'll conclude today by that.
Any questions? Online.
No, sir.
Uh,
I have one question, can I?
Yeah.